Excuse me.
How you doing, Lisa?
I'm doing good. I'm on mute. You should see us. We're like the man behind the curtain in the Wizard of Oz, running around crazy, making sure we get everything going.
It's going good.
It's me, Ron, and Cassie managing all of this. So it's been a challenge, but we never would have made it without Cassie. There's no way. How you feel like it's going? Are you
great?
pleased?
I've been kind of going in and out of sessions today. I had a big grant meeting I had to be on earlier, so I've been.
Yeah. Oh, those are always fun. I'm going to put up the slide that just kind of shows the session so people know what they're in. Hey, Becky, I see you. Do you have any slides or a presentation or anything you want to share?
Yes. I emailed them after that first panel.
Okay.
I had some problems, but I have them here ready to share, and I'd like to be able to advance them. If that's okay.
That's actually easier because, and so what I will do right now is make you the co-host.
Perfect.
Which is how you can share slides whenever you're ready.
Okay, and then I also, as a backup, have all the videos pulled up on YouTube, so I can twice share. So hopefully it will be flawless.
Very good. Excellent. All right. Well, the only thing I wanted to do is just kind of put up that cover slide.
Okay.
So people will know they're in the right session.
What I've been in so far has been some really good interaction.
That's good. Well,
yeah.
I'm really pleased because even the sessions that have a low, not a large number, it actually works better when it's smaller numbers of people because they have the opportunity to, just talk amongst themselves. And I think it's actually more productive because you come up with, better action items, more richer engagement, I think, with them.
Well, this will be 2 hours of solid information, but yesterday, the one Andy and I did, we were able to ask a couple of the pharmacy VPs and things that joined, kind of what they were doing. So to your point, I do think that we were able to have good engagement.
Good. Excellent. Well, so I'll keep this up, and then whenever you just let me know and I'll stop sharing my screen and you can share yours.
Okay. And is Cassie gonna start it with the welcome or introduction?
No, I am actually. We flipped because she has a commitment she needed to get to, and so we traded hosting responsibilities so she could make it there. And I don't know if you've had a chance to meet Amy Morawski, who's on the call. Amy is the director at the Tennessee Department of Health of the Office of Opioid Response Coordination. So she's actually orchestrating, all the people that are involved from I forget what they're called now, the regional people that they have placed in each region.
Oh, so, excellent.
So Amy's a good person to know.
Hello, Amy.
And Amy, Becky is a good person to know.
I was on mute, sorry. Plus I'm doing some work, so I have two screens going here.
I totally understand.
Came in the office, try to get caught up on a couple things, so. Nice, it's real quiet here.
Yeah. Well, thanks for joining us, Amy, and
Yep.
all the work you're doing.
Looking forward to this. I came here from Michigan, so we did a lot
Oh,
of
okay.
trauma-informed care. I worked in the mental health section for a while.
Okay. I just did a echo didactic for a group of Detroit neurologists
Oh,
at Great Lakes Great Lakes Neurology, Dr. Avery Jackson. I talked about creating trauma-informed multidisciplinary teams.
yeah, on the mental health side, that was really one of the big. SAMHSA put a lot of money into trauma-informed care. about
Yes.
2 years
Yeah.
ago. Well, actually, it was more than that, 'cause I've been here too, so about 3. Yeah, it's push time for us. We have to put our work plans into CDC, so it's budgets and work plans right now.
Is there anything you need from me on that?
No, we're all set. Thank you. We're all A-okay.
Good. All right. Well, we may have some new things coming out of this conference that we'll see. I've been jotting down really good kind of next steps, action items and stuff. So I'm eager to hear what other people, want to have moving tomorrow.
Stimulants might be one.
What might be one?
Stimulants.
Huh?
And I really want to push that co-prescribing.
Okay. Yeah. Well, in the lunch and learn session that Josh just did around naloxone, one of the ideas that came up is to connect with the Primary Care Association and Charitable Care Network to see if their clinics, which serve uninsured people, are aware of, and we feel like those are pretty good places for clinicians to be educated and equipped. Becky, I think whenever you're ready.
Want me to just go ahead and get started? Uh-oh, you're muted. Okay, I'll take that as a sign. All right, I'm going to share my screen. All right, well, thank you for joining the afternoon session of using a trauma-informed approach in healthcare. So this is a 2-hour learning session, educational session, and it's going to cover a lot of information. So I encourage you to follow along in the slides and make notes, and Lisa will have access of the slides later to share. And so what this going to cover today is to learn about trauma. What is trauma? How to identify trauma. And we're going to talk about the ACEs study. And then we're going to talk about what do we need to know about trauma and serving trauma survivors in a treatment and in a healthcare setting. So again, thank you so much for joining us this afternoon. So I'm not planning to take a break during the 2 hours. So if at any time the information, it can be sensitive, talking a little bit about domestic violence, abuse, neglect, And if you need to step away, feel free to, or if you need to, get a drink of water or something like that, feel free to. But with that said, here we go. All right, so the first module, we're going to talk about having a shared understanding of trauma and how to identify trauma. Trauma is kind of like the wind. You don't see the wind. What you do is see the effects of the wind. And then we're going to talk about the science of trauma and the science around ACEs and how it impacts brain development. Now, the training that I'm delivering to you, I've delivered to hundreds of healthcare professionals for a year and a half. I worked in our regional healthcare system as their first trauma-informed administrator. I trained one entire hospital, 700 staff in 6 weeks, cardiologists to housekeeping, to dining, security, physical therapy, everybody all together. And I use this very training. I trained another hospital, all the CEOs, all the CNOs of that health system, as well as several medical practices that sought out. So this is a content that has been widely shared in this region with those in healthcare, pharmacy, and opioid treatment, all right? Okay, so in understanding trauma, a couple things to remember is that we want to shift our thinking from what's wrong to you with a trauma-informed lens is what happened to you. And so when I first learned about this, working for the police department in Johnson City to reduce drug-related and violent crime, as well as to reduce recidivism among felony offenders with addictions, I heard the stories of trauma of young children being locked in a closet when the parents were having the drug parties, or when parents were caregivers passed out, how that the child is being violated by people that frequent the home around the drug activity. And so we might think about, as you're treating addiction, to think about, instead of the addiction, thinking about treating the trauma. And then we're going to talk about how symptoms of things like stomach aches, headaches, some physical ailments, anxiety attacks, depression, bipolar, a lot of the symptoms that people seek out treatment for really often can be adaptations to trauma. And then the good news in understanding about trauma and ACEs is healing happens in relationships. And some of the other services and panels that I've been a part of so far in this event for One Tennessee has been talking about that, how that the relationship, even during COVID, one of the presenters was talking about in an MAT program, how they were able to keep that warm connection through literally going overnight to be offering the telehealth. And then we want to help you to see how that you don't have to be the therapist role to be therapeutic. Okay, so the first little video is about 2 minutes, and it's a classic by Brene Brown, and it just explains the difference between sympathy and empathy. Oh, wait, hold on. And I believe I have to reshare. Hold on. Yep. And share send. There we go. Now I'm hoping you can hear it and see it.
So what is empathy, and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. So what is empathy, and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, you climb down. I know what it's like down here. And you're not alone. Sympathy is, ooh, it's bad, no. You want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with at least. Yeah. And we do it all the time, because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now. I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
All right, so in the video there, as the little cartoon so beautifully portrayed, that empathy is basically perspective taking, seeing something from the other side. So as I've been training healthcare professionals, in a minute, well, in a little bit, we're going to see a slide about, hold on. Okay, we're going to see a slide about some empathetic statements. So say you have healthcare workers working in a ED, and you have someone comes in as a result of domestic violence, and for healthcare staff to understand trauma-informed care, to be able to just simply use empathetic statements like, I'm so sorry that happened. I'm sorry that that's your story, where we know that that has a therapeutic benefit, while yet that healthcare person does not become a therapist. So empathy is perspective taking, staying out of judgment, recognizing emotions in other people, and communicating this recognition. So basically, empathy is feeling with people. All right, so what is trauma? We want to identify and understand the definition of trauma. I'll be on the same page. So the definition I'm using for this training is from SAMHSA, and it's kind of a mouthful, but it's an individual trauma results from an event, a series of events experienced by an individual that are physically or emotionally harmful or life-threatening, that can have lasting adverse effects on the individual's functioning mentally, physically, socially, emotionally, and even spiritual well-being. Now that's a mouthful, so let's break down the E's one at a time. Now, if we were in a small setting that we were together, we might have Post-it notes and ask you to fill in the blanks here. And you may see your own story there. I see some things in my story there, but for the sake of time and virtual conferencing, we want to look at the potential traumatic events. And the reason these are labeled potential is you and I can experience the same event and it's not traumatizing to you while it is to me. And a lot of that we learned from the ACEs study has to do with having a good support network. Okay, so some of the potential traumatic events can be abuse, and there's several there examples in the column: chronic stressors, poverty, racism, and even invasive medical procedure when we have a family member that's undergoing cancer treatment, or maybe a treatment that is going on for several months. Family members that have been hospitalized because of COVID. Or even lost to COVID, a community trauma, historical trauma, a family member with substance abuse. And that's what this event is all about, this summit. And so we know children are growing up in a home with a substance abusing caregiver. And there's a good chance that that caregiver grew up in some household dysfunction. Or we could add to that column having a family member that is incarcerated. And then in the other column of loss, death, abandonment, neglect, separation, natural disaster. When I worked at the police department, we had families that came to Johnson City after the Gatlinburg fires, and you could find some of them sleeping in their car at night at the local Walmart, and their children were coming into the school system here. And so all these type of situations could be potentially traumatic. All right, the second E is the word experience. And the experience of trauma can be impacted by how did it happen, when, where, and how often. So it's the individual's experience of the event, not necessarily the event itself, that's traumatizing. So as I was growing in my knowledge of this topic, working for the police department, I had some good conversations with some of the detectives. And when I interviewed the child crime investigator who'd been in the department over 20 years, they were telling me how that of that year, they had investigated 18 child homicides of 18 children under the age of 2 that had died. And of the 18, 16 were at the hands of the known caregiver. And basically it was through things like neglect, where an addicted caregiver would put a 15-month-old in a crib and throw in some cookies or some food and then leave for hours at a time and come back, and a child's choked to death. And I've heard of people working in the prison program and in the reentry community at ages of 4 and 5 years old, waking up and having a parent trying to take the life of the child by suffocating them with a pillow over their face. And so when things happen through known caregivers, which is predominantly the way it is, those things can certainly impact the experience of the event. And so then thirdly, the effects of trauma. So I want to start shifting your thinking now to think about the effect of trauma on an individual can make it where it's a normal response to that individual. A story that I share to illustrate this point. When I was working with a reentry population, a young woman one day in a treatment program began to tell her story of having a heroin addicted mother, and her youngest memory as a child was pulling her mother out of the toilet when her mother would shoot up if the mother's boyfriend of the time wasn't around, because the mother got very sick. And while this little girl is pulling her mother out of the toilet, the older sister's hollering across the house, "Let her drown, let her drown." And I said to that woman that day, I said, "I'm so sorry that is your memory of your earliest memories of your mother." And to that woman, it seemed perfectly normal that there were many other people that were just growing up that way. Another time when I was back over there, I told her that day I was sorry that was her memories of her mother at an early age. And I told her part of her treatment plan there was counseling, which she may have never had an opportunity for counseling in her life, but this jail diversion program now offered free counseling. And I told her that she needed to be able to talk to a counselor and to just consider how that was not a situation that she chose, because we don't pick where we start in life. And the next time I was over there in that program, she handed me a little note and it said, "Thank you, Miss Becky, for treating me like a person." So we see the effects of trauma become conceptualized as something normal to the trauma survivor. Now, this slide's important in the fact of how to identify trauma. So we see the physical, some physical, identifiers. We see emotional, we see behavioral and cognitive. And so a couple years ago, I was training 200 regional school nurses in the summer. And when I show a slide with this information, they're all shaking their head up and down, because a school nurse knows every year they'll have the frequent flyers in the nurse's office with the headache, with the tummy ache. And they know that these kids, now they're seeing that maybe these children are witnessing violence in the home. Certainly it might be a headache, it might be a tummy ache, but yet it could be related to the angst of things that are going on in the home. And then we see things with emotional, we see things behavioral and cognitive. And again, this is a opioid summit, this conversation. And so we see that the ACEs study showed, as we're going to see in a little bit, that childhood trauma without a healthy support system is a significant risk factor to addiction. And then we see the cognitive. And so I do quite a bit of training for police. I have 2 trainings in the state of Tennessee that are post-certified for officer in service. One of my trainings is also certified in the state of Oklahoma as officer training, because when officers are investigating sexual assault reporting, oftentimes they perceive these reports to be false reporting because they're delayed reporting. But when an officer understands how to identify trauma, with part of it being the ability to concentrate, memory lapses, and some of these things, then they see that delayed reporting really helps substantiate that this person actually did experience a trauma. So it's very important that we learn to identify, what does trauma look like? All right, the brain development is a key part of understanding the science around trauma. So the brain has a bottom-up organization. So the bottom controls the most simple functions, such as respiration, heart rate, and blood pressure. So when a child is born, all these involuntary functions are working, a baby breathing, their heart rate and such, and all that's being controlled through the brain stem. And in this photograph, in the red and the yellow areas, the upper part of the brain, this is a more complex area that handles things like emotional regulation, problem solving, and those areas are going to be developed, and they're going to be developed because a child is using that part of their brain. Okay, so then the other part of the brain that is important in this conversation about trauma-informed care is the amygdala. So at the base of the brain, as this diagram illustrates, a small little tiny pea pod is what we call the fire alarm of the brain, and that's the amygdala. So when the amygdala goes to work, so if while I'm doing this training, I hear a scream from the other end of the building, and someone says a bear has gotten into the building. Well, all of the activity in my cortex is going to shut down, and my amygdala, I'm going to change gears without any help on my part. It's just my response to hearing danger. My amygdala is going to go hard to work. And that's why in a crisis, it's hard to think. However, the thing with the amygdala is it can only produce 3 activities or 3 types of behavior: fight, flight, or freeze. So now, as I'm training educators, on Saturday, I'm going to be training early childhood educators across the state of Tennessee. And this is critical for educators to understand. In my role as a consultant for the ETSU Strong Brain Institute, we're helping to lead a national conversation of universities and colleges. We had our first one back in March. We had 8 universities to join, all the way from Oregon to Florida. And we're seeing dedicated faculty members working now to build courses and put this into coursework for pharmacy and for education and for preschool and for medical school, so that we're understanding these behaviors as we're getting our professional training, instead of having to go back 5, 6, 10 years later and have some sort of professional development around it. So we see the typical brain development on the left here is where there's a small amount of the amygdala is developed for a child living in safe, nurturing conditions, and a whole lot of attention to the cognitive part. However, on the other side, we see what the brain looks like of a child the same age who's growing up in a home with household dysfunction. When I worked for the police, the school board members told me that in the city schools here in my town, that every year 300 to 400 children are classified as homeless. Now, it doesn't mean they're sleeping in a car or under a bridge somewhere, but it means when the child leaves that day and goes home, the teacher has no permanent address to find that child. That kind of child growing up in that type of instability is not developing the upper part of their brain because that caregiver may be going from drug party to drug party, couch surfing. Is there going to be a meal? So that child's brain is highly developing in the survival part of the brain. So now, teacher, you're going to have two kids come in side by side, and one has the top part of their brain developed while the other has more highly developed the bottom. And also now we see people then growing into adulthood, and this is the same type of brain activity. And when I oversaw the prison program, we saw early on that we could not do the job skill training immediately in this 12 to 15 month program. We saw that we had to focus on the healing from trauma, the drug, focusing on the sobriety for the first few months, focusing on relapse prevention. And then we found that these individuals were taking in the job training much better, and resume writing and that. Why? Because we're helping them to begin to strengthen this upper part of the brain. All right, here's a little video. It's in cartoon fashion, about 4 minutes. It's going to show how brains are built.
Science tells us that the experiences we have in the first years of our lives actually affect the physical architecture of the developing brain. This means that brains aren't just born, they're also built over time based on our experiences. Just as a house needs a sturdy foundation to support the walls and roof, a brain needs a good base to support all future development. Positive interactions between young children and their caregivers literally build the architecture of the developing brain. Building a sturdy foundation in the earliest years provides a good base for a lifetime of good mental function and better overall health. So just how is a solid brain foundation built and maintained in a developing child? One way is through what brain experts call serve and return interactions. Imagine a tennis match between a caregiver and a child, but instead of hitting a ball back and forth across a net, various forms of communication pass between the two. From eye contact to touch, from singing to simple games like peekaboo. These interactions, repeated throughout a young person's developing years, are the bricks that build a healthy foundation for all future development. But another kind of childhood experience shapes brain development too, and that's stress. Good kinds of stress, like meeting new people or studying for a test, are healthy for development because they prepare kids to cope with future challenges. Another kind of stress, called toxic stress, is bad for brain development. If a child is exposed to serious ongoing hardships like abuse and neglect, and he has no other caregiver in his life to provide support, the basic structures of his developing brain may be damaged. Without a sturdy foundation to properly support future development, he is at risk for a lifetime of health problems, development issues, even addiction. It's possible to fix some of the damage of toxic stress later on, but it's easier, more effective, and less expensive to build solid brain architecture in the first place. One of the things that sturdy brain architecture supports is the development of basic emotional and social skills, an important group of skills which scientists call executive function and self-regulation can be thought of like air traffic control in the child's mental airspace. Think of a young child's brain as the control tower at a busy airport. All those planes landing and taking off and all of the support systems on the ground simultaneously demand the controller's attention to avoid a crash. It's the same with a young child learning to pay attention, plan ahead and remember, and follow lots of rules. Like all of us, kids have to react to things happening in the world around them, while also dealing with worries, temptations, and obligations on their minds. As these demands for attention pile up, air traffic control helps a child regulate the flow of information, prioritize tasks, and above all, find ways to manage stress and avoid mental collisions along the way. Having this ability is a necessity for positive and level mental health. Developing effective air traffic control, overcoming toxic stress, and building solid brain architecture are things kids can't do on their own. And since strong societies are made up of healthy, contributing individuals, it's up to us as a community to make sure all young people have the kinds of nurturing experiences they need for positive development. To build better futures, we need to build better brains.
Oh, shucks. All right. Okay, so this video, a couple of key concepts that we learned in that video. One was how that for a child to develop healthy brain function in the cortex, they have to have a process called serve and return. Now, I'm kind of speaking to the choir today, because if you're involved in treatment programs of any kind, you know that individuals, kids that are growing up in a home with an addicted caregiver may often be neglected or left alone. Sure, the caregiver may be there physically, but is that child having books read to them, or, going on a walk outside or to the zoo, or just playing with toys together, where you're getting this activity that's serve and return? Well, in that video, it referred to serve and return as building the bricks. Then it went on to say that one of the buildings that you will need to build as a child with the bricks is air traffic control or emotional regulation. So in my lifetime, we've seen a real swing to a lot of emotional outbursts where children in school, young people, in the store shopping, on the freeway driving, where people seem to have emotions that are huge and set off. And that could be an indication that as a child in those developmental years, they're not getting the serve and return, getting the bricks, and building the air traffic control, the emotional regulation. All right, so this is a slide that comes from the Tennessee Building Strong Brains. I was trained as a trainer in building strong brains in the first cohort they did in 2017. So I incorporate some of their great messaging in many of my trainings. And so if you'll notice in this slide, there's a little gal in a pink top that's in each of these scenarios. So let's follow her and see what happens different in each scenario. So there's positive stress. So, maybe meeting new people, my little grandchildren when they're babies or small toddlers, going to see the Easter Bunny or Santa at the mall. As a grandma, I hated seeing pictures of them sitting in this large rabbit costumed individual that I know is safe, but that child is got a look of kind of panic on their face. They don't know if this huge rabbit, what are they going to do? But after they understand that it's just a person there in a costume, or you get that job after the kind of interview that was maybe a bit nerve-wracking, or maybe public speaking, then it kind of bolsters your confidence to go on and take on new challenges. But notice now in the middle, the little girl's moved over to tolerable stress, and notice how much larger the boulder got. Now, the death of a family member, that's very, very significant, but notice how she's able to navigate. Could she navigate that by herself? No. And so she's got a support system at the top. Now look at the far side there. Look at how much larger these boulders are. And they're labeled parental addiction, abuse, neglect. So this is toxic, ongoing stress. And this is impassable to this little girl. And not only impassable, but she has no support system. And if you see the words there, it really indicates that what should be her support system is the source of the toxic stress. And so if we get scientific about it, the next slide illustrates the amount of stress that a child growing up, the positive stress of the interview, or going into first grade or something like that. It's stressful at the time, but then notice that the stress becomes manageable. And then in the middle scenario, losing, a matter of fact, I had dinner on Monday night with a friend in Abingdon who is here in town because her mother passed away, and she's come up from another state to work around settling the estate and all. And so this will be a first Mother's Day without having her mother here. And so you think about the stress of that situation, and it'll go down. But a birthday or a special occasion will trigger it up again. But again, notice over time, typically with a support system, this becomes manageable. But then look at the toxic stress, where we have the stress never dimming. And that right there, in my mind, was a reason that I was offered a role to move from the police department to healthcare, because now we know there are studies out there that show that too much toxic stress, when your amygdala is like fire hose, too much cortisol is being released, then it's producing certain types of cancer, COPD, heart disease, and it's an underlying factor in many of the health causes in our region today. All right, so this is a simple activity that comes from a book by Dr. Dan Siegel on the Whole Brain Workbook. And whatever audience I work with, I help them to understand the upstairs and downstairs brain. So if you just think about your fingers, the top 4 fingers are the cortex, your thumb is the amygdala. And while you're listening to this training, you kind of look at your brain like a fist, and your amygdala is all wrapped around, tucked in, your cortex is hard at work, remembering the details, listening to my stories. But if the bear runs in the room while you're involved in this webinar, literature calls this flipping your lid, and your cortex shuts down and your amygdala goes to work. Now remember, the amygdala can only produce fight, flight, or freeze. So that's why I'm training teachers, preschool educators, nurses, doctors, police officers, judges. When we see downstairs brain, fight, flight, or freeze, we're not going to be able to resolve conflict with that individual because they're not in the right room. And so through some simple techniques like deep breathing, little things like fingertip push-ups for children, a lot of schools that I work with are adding calming rooms. The Boys and Girls Club that I'm on the board of, we've added a calming room. What are we doing? We're helping children navigate from the downstairs brain back into the upstairs. So are these really problems, or are they adaptations to trauma? The amygdala responses are only 3, fight, flight, or freeze, and they're activated by danger. And these 3 sets of problems are often attributed to a child or adult. It really shows that these behaviors, instead of willful behavior, it could be survival behavior. And so we want to recognize these symptoms and problems, behaviors, as adaptations to trauma. It'd be like if I was doing this seminar in person today and I had my arm in a cast, or I had my foot in a boot. Well, you would reason that maybe I'd had surgery or had an injury, because why? You would see some sort of physical adaptation. So now we want to look at these behaviors as truly telling a story that it could be related to trauma adaptations. And they're pretty self-explanatory there: fight, flight, freeze. So some of the factors that can increase the impact of trauma is early occurrence, blaming or shaming, being silenced or not believed, and perpetrator is a trusted caregiver. See, there's 2 types of trauma. There's natural trauma, which is things like a tornado, a Gatlinburg fire, a global pandemic of COVID-19, which are very public, very out there. In this past year, we've been honoring our healthcare heroes. We've been following the CDC, sometimes almost every few hours to see whether we're doing virtual or in person or masking or vaccines and all that. So it's very public. But where have we been on the secretive, the created trauma, domestic violence, many that are coming into our world in the addiction epidemic have suffered these created traumas that have not been so public. And that's why I'm really thrilled to be able to be sharing this today, and why groups such as One Tennessee are starting to share the knowledge about trauma to get it more out into the public attention as a risk factor to addiction. So what does trauma look like? In a healthcare setting, it could look like this. Sometimes You have to talk to patients about some hard news. So it could be depression, or maybe something just going on a long time, or there could be disconnect or aggression. And then later on in the training, we're going to touch on the secondary trauma of the providers. Okay, so what is a trauma-informed approach? So I hope at the end of this session today, it will be like I handed you through the screen a pair of glasses, and that like going through a 3D movie where you put the glasses on so that you can better see the way that the movie was prepared with digital, concepts and things where the fish are swimming at you if you're in the ocean, or whatever the movie's about. But I'm hopeful that this training will hand you a trauma-informed lens to see the story of trauma survivors that you serve in your practice or your treatment program, as well as ones that are also a part of your staff. So a trauma-informed care, it just serves as a strategy. If the only tool you have is a hammer, then you view every problem as a nail. So this training today is to help you to see some more tools that you can bring into your setting to help have a better, more effective service delivery. So it's a strategy to help healthcare agencies gain the awareness, the knowledge, and the skills to better support traumatized individuals and ease pain management. This approach prompts service providers to be aware of the recipient's psychological and emotional needs when providing medical services. And it also necessitates that a service provider approach recipients from a perspective of empathy and compassion that rejects ideologies of individual blame for life issues that have been created by many life factors. After I was training some nurses in a setting where mothers were coming in and that were addicted and having babies. Some of the nurses reported to me, after understanding about the trauma that likely exists in the mother's life, that though that you certainly don't want to condone someone with an addiction now giving birth to a second, third child, because now the NAS babies, there could be some factors there, but now they felt more empathetic to the mother, understanding that often that the drug addiction could be self-medicating from the things experienced in childhood. And so a wonderful book, if you have not read it yet, that you should add to your library. It's called Compassionomics. Comes from a couple of doctors at the Cooper Institute. And I'm going to refer to some of the wonderful content here in this training. But one of the things that they point out in that book, and it's about bringing compassion, examining the compassion that we bring into a healthcare setting. And so in that book, they talk about how the historical provider training consists of two things: the science of medicine, how to treat patients, and then the art of medicine, how to take care of them. But what they showed after a systematic review of over 1,000 studies that dated back over decades, they weren't able to do a PubMed search and just say compassion in healthcare, but they also had to look under words like empathy or connection, some different things. But they ended up with about 1,000 studies that this book was written on, and they found overwhelmingly that when the provider adds an intentional element of compassion into the system, that it helped the patients to heal at a better rate, as well as to prevent provider burnout. And so what this book really, a lot of it is about, is how that evidence shows there is actually an overlap between the science of art, between the science and the art of medicine, that there is a convergence. And if compassion for patients is found to be a highly effective therapy that changes outcomes, one that is so much more cost effective than other therapies utilized, it should become a part of every caregiver's toolbox, and that we should use it on every opportunity. And there are some amazing, amazing stories throughout that book, just talking about the doctors and the nurses and that took the time to be involved in a small way, a very small way with the patients. And so seeing this convergence of the science and the art. All right, so on our next module, we're going to shift gears and talk about the actual adverse childhood experiences study and the prevalence of trauma. Then we're going to wrap it up by talking about what does this look like in a health and a treatment setting. All right, so the learning objectives in this module, we're going to talk about the actual ACEs study that was conducted in the late 90s. Again, how to recognize, and then we're going to talk about the prevalence of trauma, and then what does trauma-informed healthcare look like? All right, so this video is a 5-minute primer on the ACEs study. It gives a great summary of the ACEs study.
What does your parents' divorce have to do with your risk for heart disease? If your mother had a drinking problem when you were growing up, are you more likely to suffer from depression as an adult? Here's what you should know about ACEs. ACEs stand for Adverse Childhood Experiences, extremely stressful events that can happen to a child growing up. Some experiences are so stressful that they can alter brain development, as well as the immune system, increasing the risk of lifelong health and social problems in adulthood. The term comes from the Adverse Childhood Experiences Study, landmark research that shed new light on the root cause of everything from stroke and liver disease to substance abuse and mental illness. In the late 1990s, an epidemiologist from the Centers for Disease Control and a preventive medicine doctor at Kaiser Permanente set out to understand the association between childhood experience and lifelong health. They asked over 17,000 people in the Kaiser Health Plan in San Diego about their health history, as well as difficult questions about their experiences growing up. Anda and Felitti tallied up 10 different kinds of adversity in this largely middle-class and college-educated population. They were stunned to see how common ACEs were. 21% of all respondents were sexually abused as children. 19% grew up with someone who suffered mental illness. 28% had been physically abused. And 2 out of 3 respondents had experienced at least one ACE. The researchers next looked at how someone's ACE score, or the number of adversities they experienced, related to a wide array of serious health and social problems. They saw that the more ACEs someone had, the greater their risk for poor outcomes compared with someone with no ACEs. Someone with an ACE score of 4 had twice the risk of heart disease and cancer. Someone with an ACE score of 5 had an 8 times greater chance of being an alcoholic. And those with an ACE score of 6 or more, on average, died 20 years earlier. With every major problem they looked at in the ACE study, the risk went up for each additional adverse experience in childhood. As Dr. Robert Anda says, what's predictable is preventable. It's important to remember that ACEs are not destiny. ACEs are a tool for understanding the health of a population as a whole. For individuals, an ACE score can be a tool for understanding their own risk for health and social problems, and empower them to make changes for themselves and their children. ACEs tend to get passed down from generation to generation and are common across all income levels, races, and cultures. But increasingly, people of all different professions and backgrounds are coming together to discuss how ACEs affect their communities. They're finding new ways to treat and prevent ACEs. Many doctors are starting to screen their patients for ACEs as part of their medical history. More schools are becoming trauma-informed, considering the source of problem behavior when disciplining their students, instead of immediately suspending or expelling them. To learn more about interrupting the cycle of adversity and improving health and well-being for the next generation, please visit kpjrfilms.co.
All right. So what did we learn from the ACEs study? Well, we saw that the two doctors that came together, Folletti and Anda, they actually were doing work independently, and then they learned about each other's work and came together and formulated the 10-question ACEs survey. Now, since the late 90s, when this was developed, there are no other variations of it over time, like Dr. Roy Wade with the Children's Hospital of Philadelphia, as he was going through Harvard, finishing up his medical school, he did a inner city version there in Philadelphia. And one of the original ACE questions, you saw him scrolling on the screen there in that little film, 10 questions, 5 things did you see this in your home before you were 18, and 5 things did this happen to you. And one of the questions was, were your parents ever separated or divorced? And Dr. Wade said, to kids in inner city Philadelphia, it was a luxury. None of them had parents separated or divorced. That a percentage of them didn't even know who a mother or a father were. And so, they saw that could not really be a question, but they added questions like community violence or bullying to fit the population, because in the ACEs study, it ended up being 17,000 people enrolled in Kaiser Permanente, the largest HMO in California. And at the time, it ended up that most individuals were around 53 years old, college educated, and Caucasian. But what they found was that ACEs are not, they're widespread, more widespread than I think it was ever thought. So when life is filled with adversity as a child, whether you're witnessing violence in the home or, addiction in the home or neglect in the home, the CDC says that the greatest form of child abuse is child neglect. And that can certainly come, that's no socioeconomic home life. There's no barrier. It could be two parents with busy careers and a child, left often unattended. I heard an interesting report the other day. My boys, our boys are in their 30s now and married. One has children. And I remember when this happened, but they were talking about the Baby Einstein products and how that when the Baby Einstein products came out, the goal was that the screen time of these little segments of learning that were age appropriate to children under the age of 1 or 18 months or 2, that it was going to help prepare kids for school. And no doubt that it did some, but they found that as these products took off and began to spiral to the top of the market as bestsellers, that actually that it replaced the human contact time, and the children were not necessarily getting better results and better preparedness for school, because the screen, you do not get the serve and return. You're not getting that human connection. And now, since the ACEs study, we've learned a lot about child attachment, secure attachment, and how critical it is. Last week, I was speaking to a group in Cumberland County, Tennessee, working with the mayor and working with the police chief and the school district superintendent to help become a trauma-informed, more resilient community. And I was sharing with them how that a lack of relationships is what broke this. And so now the ACEs study showed us that human connection is what helps to repair damage done. So when the ACEs are the foundation of life, that creates toxic stress that leads to altered brain connections, which is going to lead to poor school performance. And then substance abuse and early age alcohol, tobacco use, teenage pregnancy, risky behaviors to begin to cope with these types of adversities. And those are going to lead to poor school scores in school, poor physical health, mental health, addiction, incarceration, and early death. So the educating on the impact of trauma. So when I first learned about this in 2014, again, working for the police department, I just did a quick search at the American Heart Association. And in my lifetime, I've seen where healthcare plans have made this shift to a lot of education. And in my healthcare plan, if there's a marker for pre-diabetes or obesity or anything like that, they want you to partner with them in helping to improve your health by increasing your amount of exercise, decreasing your amount of calories. And sometimes I've worked with a nutrition counselor in health plans. And so in my life, I've seen where there's been an increase in education around these things to improve heart health. And so when I pulled up the American Heart Association, I saw that individuals that don't exercise can increase their rate of heart attack by 12%. Tobacco users can increase their chances of heart attack by 50%. And professionals that are joining today, I want you to think about the amount of public education that exists related to exercise and smoking cessation. But in the ACEs study, Dr. Folletti and Anda found that if a man answers yes to 6 of the 10 questions, and if one of them is, did you witness violence in your home against your mother or stepmother? And I know from working for police, very, very, very seldom does it ever happen one time. If a child witnesses violence in the home, typically it's ongoing, but the ACE test, what it did was just ask you to answer one time, did it happen? So we know that it could have even had a multiplying effect by witnessing it more commonly. But it said that a man with an ACE score of 6 is 46 times or 4,600% more likely to become an IV drug user than a man with an ACE score of 0. And in my police programs, we won twice national awards. In 2014, I accepted an award from the National Criminal Justice Association for our work as a community to reduce crime. One of our neighborhoods, we reduced drug-related and violent crime by 40%. We also created the prevention program for the reentry community, ended up becoming a state model. About 3 months ago, I saw on the news that Governor Lee allocated $4.7 million to the Tennessee Department of Corrections to expand the day reporting center across the state. And I helped to oversee the development of that program at the Johnson City Police Department. And I wondered, getting as high as up to the president's cabinet in 2014 and with the United States Department of Justice, I wondered, why was I not hearing anyone talk about ACEs, talk about trauma as a part of our toolbox in overcoming the epidemic of addiction? And so that's when I began to make some noise about it. So trauma and mental health. So these are statistics from the SAMHSA website and the SAMHSA concept paper that was written in 2014 that encouraged a public health approach in communities to address childhood trauma through an educational approach by training a cross-sector of professionals, which is what we've done here in Northeast Tennessee. So in the mental health area, history of childhood trauma predicts earlier first admissions, more frequent and longer hospital stays, more time in seclusion or restraint, greater likelihood of self-injury or suicide attempts, more medication use, and increased symptom severity. And then again, national statistics. So around 65% of all substance abuse treatment clients report experiencing childhood abuse. 75% of women in substance abuse treatment have histories of trauma. Around 92% of homeless mothers have severe trauma histories. During my tenure at the police department, I led the homeless task force, working directly with the mayor and the city manager of our town. And I saw in 2013, the American Journal of Public Health talked about how that homeless individuals have the highest ACE scores of any population sampling. And the Bill Gates Foundation on Ending Homelessness says if we ignore the piece about trauma in the lives of homeless, that could be the single greatest key to solving and reducing homelessness in our communities. And then we see the prevalence of trauma in children. National statistics, 71% of children exposed to violence. And this is something that, you know, as a grant writer and a grant program manager and educational developer, almost all my career, I'd never seen numbers this high that totally related to the challenges that I could sit in city commission meetings. And then when I went to healthcare, hear the costs of raising the budgets to build more in-treatment bed, to get more mental health providers, to have more NICU space because of the number of babies being delivered. And though these things are helping address that, I couldn't see that it was helping to push it backwards. And so we see 71% of children exposed to violence each year. 3 million children maltreated or neglected, 3.5 million to 10 million witnessing violence in the home. And the reason for the large gap there in the number from the low end to the high is that statistically it takes 7 acts of violence for a victim to report it to an advocate. Now, they will report it to police earlier if there's violence, if there's strangulation, if there's physical injury or beating. And many times those individuals are coming in through our ED, but typically someone will not seek out help to leave that situation until 7 acts of violence. And in Europe, it's 35 acts of violence. Matter of fact, this morning, I was on the phone with a university student in Lithuania. I've been mentoring a group that's working with the Red Cross in Lithuania. If you Google who is the country that leads the world in the amount of deaths by suicide, it's Lithuania. 1 of every 3 people in the country of Lithuania will die by suicide. Until recent years, domestic violence was not even a reportable crime. The most dangerous place for a woman in Lithuania is in her own home because of the violence in the home. So children are witnessing this violence in the home. 1 in 4 girls, 1 in 6 boys sexually abused before adulthood. Now look at this number. In a study of juvenile justice, 94% of children had experienced trauma. What if I was on a call today and I was able to say to medical providers across the state of Tennessee, I know 94% of why individuals have Alzheimer's or have cancer. You know, we're talking like Nobel Prize stuff here, but what if we look at almost implies that maybe we could reduce the amount of juvenile justice settings if we came up restorative practices or built in some additional layers of buffering and mentoring for children and youth, because 94% of all the children in juvenile justice in these studies that have been done have experienced childhood trauma and ACEs. And so what is trauma-informed healthcare? Well, again, it's a strategy. It's a mindset. I like to call it a lens that encourages service providers to be aware of the recipient's psychological and emotional as well as physical needs. Also, to approach recipients from a perspective of empathy, not blame for the life issues that may be a result of or in response to trauma. And it treats service users as equal, valued human beings. You know, I saw working with the reentry population how often, and my friend, Dr. Andy Clements, a psychology professor that got very involved in that reentry program with me and helped me to begin to educate our community, and together we pioneered the trauma-informed system of care in this region. We decided that we should eliminate from our language them and us, because the thing is that who would pick where they start out in life? And so beginning to infuse empathy into our conversations as we deliver services. So treating service users as equal valued human beings, and then to acknowledge trauma and have an empathetic response. if the service user wishes to open up about their story. Now, a lot of things about trauma-informed care is not about knowing the story. If you're in a therapeutic setting and you're a counselor, the story may come out. But what my hopes are as a trainer and a coach on this topic is to help professionals have the skills to be able to deal with the lingering effects of the trauma, to help people like police officers understand to use open-ended questions when you're doing a sexual assault report. And instead of kind of a demanding tone, well, tell me what happened. When did this happen? Because what does that do? That eliminates control from the person. And if they're overwhelmed with the trauma of this experience, and now you're asking them to relive it, you're going to get a lot better response and actually more details if an officer will say, tell me what you remember about this. And if the officer will begin the session by saying, now we're going to talk about some things that are uncomfortable. And if you need to get a drink of water or have some tissues there in plain sight. And so what is that doing? That's helping the victim see from the get-go that the officer is understanding of trauma. And so we want to see that some of these things can help us to have skills that are going to bring about some better outcomes. All right, so a great metaphor that came out in the Tennessee Building Strong Brains to think about resilience and trauma is charging stations. So you want to look around your healthcare and your treatment setting, and in a minute, we're going to talk about some things like aesthetics and signage, but what are we doing in our setting and in our environment and with our personnel as far as interactions that is like a charging station. Stress drains our batteries, but resilience can recharge us. And all of us, whether you're the cardiologist or the prescriber today that's on this training, or a nurse or physical therapist, pharmacist, any of us in this training today, we all need charging stations. For me, I love to ride my bicycle, and we have rails to trails here in our town. And I fortunately am just 5 minutes from jumping on the bike trail. And I ride my bike. I'd ride it 7 days a week, about 12 miles if the weather's allowable. That's how much I enjoy it. And a physician friend texted me the other day, and she's single, and said, you know what, if you ride your bike, I'd love to get out there and ride with you. And though I would thoroughly enjoy her company, honestly, sometimes I like those rides just by myself, listening to music or a podcast, and just charging my batteries. So we want to know too that charging stations are going to change over time. Say if it's a grandparent or a coach, well, in time you may pass through that relationship and not be as accessible. Say a high school basketball coach that really was a great influence on young people, or a young person. So we have to realize that they change over time, and we need to be mindful of what is our charging station. Okay. All right, so the last thing we're going to talk about is trauma-informed approach in healthcare, okay? And so we want to give some examples of what this looks like. So as far as the things that we're going to cover in this session, we want to talk about how we can operate with the universal expectation that trauma has occurred. We're going to talk about the 4 R's of what does a trauma-informed program look like, and then why understanding trauma is important in healthcare. And then we're going to wrap it up by talking about the 6 SAMHSA keys to creating a trauma-informed healthcare setting. All right, the first thing, we're going to watch a very short little video about trauma-informed healthcare. Truly, it is my favorite new video. But in this, it's going to talk about 5 key messages to bringing trauma-informed practices into a health setting.
You know the old saying, don't judge a book by its cover? Well, the same is true when you assess a patient. Hi, I'm Dr. Cruz. Early in my career, I noticed a pattern with some of my patients. They often had multiple health issues, were uneasy during office visits, and frequently visited the emergency department. But worst of all, they never got better despite multiple visits. Then I realized something. From an early age, many of my patients were exposed to trauma and adverse childhood experiences, or ACEs. This includes emotional, sexual, or physical abuse, violence, neglect, discrimination, poverty, and other adverse events. ACEs are more common in the US than you'd think. In fact, 60% of US adults have one ACE, 25% have 3 or more ACEs, and 16% have 4 or more. ACEs occur in all socioeconomic groups, but are more common in low-income and minority populations. For young children, repeated exposure to trauma can impact brain development and literally rewire the brain's response to stress. So as they grow up, many struggle with issues related to emotional regulation, like depression, anxiety, or substance use disorders. Trauma survivors are also more often at risk for chronic diseases, behavioral health problems, and even suicide. Knowing all this, I began to rethink my approach to care. Instead of asking patients, "What's wrong with you?" I ask, "What happened to you?" Recognizing that life experiences are often a root cause of poor health is integral to improving patient care. Trauma-informed care has helped me take these experiences into account, providing greater insight into my patients' needs and how to address them. Here are 5 key ways that healthcare organizations can gradually integrate trauma-informed care into their practices to help patients and staff. First, build awareness and generate buy-in. Involve both staff and patients in adopting a trauma-informed approach. Second, invest in a trauma-informed workforce. Hire staff that embrace trauma-informed care and provide training not only for clinical staff, but also for non-clinical employees like front desk workers or security guards, who are often the face of your organization. Next, create an environment that is safe and welcoming for patients and staff. Engage patients in meaningful ways. Ask how they feel and listen. You can also build trust by involving them in their own treatment planning. Finally, identify and treat trauma. Consider a screening approach that works for your patients and ensure that treatments and referral sources are available. These changes take time, but each step improves our ability to connect with and care for patients. Today, our patients appreciate the changes we've made. Plus, our staff is more in tune with patients, so work is less stressful and more rewarding. Trauma-informed care. It can truly transform the caregiving experience from being treaters to being healers.
Okay, in that video, talked about 5 ways to begin to integrate trauma-informed into healthcare setting. 1, raise awareness. A lot of times when we think about service delivery, do we have a mechanism where we allow evaluations or even doing something as simple as a focus group from time to time to talk about patients? When I was working at the police department and we were starting up a family justice center, which is a program that helps people navigate domestic and sexual violence. It's not a shelter, but it is a place where people can come into a clinical setting, but yet it's a one-stop shop. So they have prosecutorial, they have legal, they have law enforcement. And when the person comes in, it's a truly trauma-informed model that they tell their story one time to a navigator, and then the navigator helps them to address whatever services that they would like in that setting. And so when we were getting ready to find a physical location for this, we did a focus group of trauma survivors. And we talked about what kind of setting would you feel comfortable coming into? Those in law enforcement know 2 things. 1, domestic violence is one of the hardest crimes to prosecute because individuals that come out after violent acts oftentimes are intimidated and bullied and feel fearful of going through with a situation. And also they're leaving behind the only car they have to drive or the income they have or the roof over their head. And so it takes quite amount of courage to be able to step out of that situation. And then the other thing is helping people to realize that with children, what's your connection going to be like where your children are concerned? And then it's also police understand that domestic violence situations can be very, very dangerous to not only officers, but others that are around. And recently in our news, as well as national news, there's been incidents of violence and fatalities through shooting, and some of it was rooted in domestic. And so when we did a survivor group about what type of location, I learned things I wouldn't have learned had I not seen it through the eyes of survivors. And they talked about being in a treatment room where they could always see an exit sign. Why is that? Because many times the perpetrators, through their intimidation, talks about not being able to get away, or if they were to have the perpetrator to show up at this place, how are they going to, be able to get away to safety? Or they talked about they brought their children, that they wanted their children there with them, but they didn't want the children in the treatment room. And so we ended up creating a facility that had a window, and we had university interns that came and helped to take care of the children in kind of a play setting, while the caregiver could see the children through the window, but yet in confidentiality talk about that. So we talk about these different types of setting and help raise awareness. And through doing that, sometimes do we get the input from the people that we serve? And then the video also talked about invest in staff training. And that's what I was doing when I worked at healthcare, helping us all to understand. And you notice there in that video, it talked about training even your frontline providers. And with the one hospital where I trained the 700 in 6 weeks on this very training you're getting this afternoon, the head of security, who had been 30 years in law enforcement, and then his retirement career was to head the security at that major hospital, he said to me, he said, how come this is the first time I've ever heard this in my life? And he had 2 daughters that were both in healthcare in other states. And he said, I'm going to call them tonight and tell them about this backstory of trauma. And so a light was coming on in his mind as a security. And so then it talked about your aesthetics. Is your environment welcoming and inviting? And we'll talk more about that in a minute. And then encouraging the patients in listening to their story as you talk about treatment plans and future medical plans. And so we're going to go through that a little bit more, but that little video really illustrates it well. So why is understanding trauma important? So we need to be aware of life situations that might be contributing to the person's current medical problems, that health problems faced by people that might be related to traumatic experiences, and that research has shown a decrease in doctors' visits in patients who received empathy from healthcare providers when they became aware of related trauma. Again, when I worked for police, human trafficking is something that every community is aware of. Before COVID, I was in the Atlanta airport and moving from one tarmac to the other on the little train, and the little message playing, looping in the train was about human trafficking. And if there was any suspected human trafficking, that it needed to be reported, because Atlanta is a huge clearinghouse for people being trafficked into sexual crimes and all. And did you know that during the time that people are in captivity, I think the statistics around 80% of those that are in some sort of human traffic capacity, around 80% will have contact with someone in healthcare, but yet healthcare professionals are only about 5% of healthcare professionals are ever trained to know the signs and to recognize what that traumatic situation may look like in serving someone that comes in the ER or comes in for some sort of an exam, and they're actually in captivity. And so we want to think about all the different kind of traumatic situations that might bring someone in for actually a physical exam. Okay, so trauma survivors are also very sensitive to situations that remind them of the people, places, or things involved in their traumatic events or triggers. These triggers may cause a person to relive the trauma and view our setting, our organization as a source of distress rather than a place of healing. So, why do we have this conversation today? Why should medical settings need to be reconsidered, maybe? And they might be distressing for people with their trauma experiences. Well, think about it: invasive procedures, removal of clothing, the physical touch, the power dynamics of a relationship, the gender of the healthcare provider, personal questions that might be embarrassing or distressing, the vulnerable physician, the physical position, and then a loss and lack of privacy. Now, some of these things we may not be able to change, but when training nurses and doctors, oftentimes now they report telling me that when we get ready to do invasive procedures, removal of clothing, physical touch, things are said like, all right, we're going to turn the light off now. Would you like an additional blanket? Or if they have, it's a situation where a person of support can be on hand, would you like to have them to come into the room as well? Now, I know a lot of that is pre-COVID and hopefully at the time post-COVID. But just thinking about a medical setting can already be distressing. A friend of mine who was speaking about trauma in a downtown Manhattan hotel in a big grand ballroom, about 500 people were at her conference. And this was after 9/11. And during the middle of the conference, there was a fire alarm that went off. The hotel management came into the ballroom and said, word got to her on the platform that it was an actual alarm. It wasn't a drill, that they did need to evacuate this hotel. And so 500 people are outside loading on the elevators in downtown Manhattan to exit this hotel. Now, on the 5th floor above the ballroom was the cafeteria or the dining room where the food was being prepared for catering and such. And in the hustle and bustle of clearing the building, several of the dining carts in the 5th floor were overturned. So while hundreds of people were in the stairs exiting the building in downtown Manhattan, they hear crash, boom, bang. And when they finally all got out of the building, the fire department came and cleared the threat of physical safety, told the organizers, you can go back in and resume your conference. There were so many people in the parking lot that were that triggered by that scenario that they had to actually cancel the conference and schedule to finish it at a later date. And so we may know the setting is safe. We may know that the activities that we're going to engage in are safe, but many of the type of things that are going to happen, someone's going to physically be in our exam room, but it's going to trigger them to be actually somewhere else. Now, when I'm training teachers, I talk about when they transition children from this room to that room. Often teachers have used turning the lights off as a transitioning signal, but to children, that may be a triggering signal because bad things have happened in the dark. So we're teaching them to use a song or use a bell or use some chimes or something else instead of turning off the light. So a trauma-informed environment is where patients and family are treated as equal valued human beings. The staff and volunteers are aware of boundaries, things like touch, turning off the lights. Often we could just give a quick indication of what actions we're about to take. We want to be sure to use language that communicates empowerment and recovery, put-ups and not put downs, and that punitive approaches, shaming techniques, and intrusive monitoring are avoided. That actions and words that might be re-traumatizing are avoided. And we have to remember that a hospital admission on its own can be traumatizing to many, and that conflict is dealt with through negotiation. And here's some examples in my next several slides of what are some things that I've found that are there that are progressing in healthcare as far as a trauma-informed approach. This approach comes from the Children's Hospital of Philadelphia. And when I was working in healthcare, I got permission to share this with the staff in the health system I was working in. And we adapted it actually, instead of just as a program for children, we adapted it as a program for every patient. And so this is called the D, E, and F protocol. And I put the little logo there at the top. So you can actually go to Children's Hospital Philadelphia CHOPS and look for this symbol, and you can actually take a module around D, a module around E, and a module around F, and they have free CEUs that are offered for going through those little modules. And so why D, E, and F? Well, A, B, and C is kind of first steps in medical school training. And we recognize that they stand for airway, breathing, and circulation. So just through the simple reminder of A, B, and C, we think about what are the critical things that need to be taken to save a life. And then after attending to the basics of physical health, the ABCs, then to do a trauma-informed approach, we want to continue on the alphabet with D, E, and F. So D stands for distress, E for emotional support, and F for family. So D is distress, E is emotional support, and F is for family. And I don't have time in this training today to go into greater detail about how we could implement those, but for instance, in distress. So in the typical amount of time that someone's being served in a healthcare setting, we might want to just be more aware of smells and sights and sounds and bright lights and things that might be distressing. Really, one as simple as turning off the lights, which I know some types of medical procedures, we need the lights off so the testing equipment can run and all, but still just to address the fact that we're turning off the light. So finding ways we can eliminate the patient distress. And then E, emotional support. Oh my, I'm sure everyone on this training today could talk about during COVID-19. I'm sure if you have served as a provider or maybe as a person, as I have, where close friends or folks that like grandparents that, succumb to illness or COVID in a hospital, and we're not even allowed to have visitors because of the pandemic. And so when we're thinking about how critical emotional support is, could we not use FaceTime or, use some sort of technology? This weekend's Mother's Day. And what about families that may not be missing their family or their mother or their grandmother? What if a nurse just suggested, do you have a FaceTime lined up this weekend? And all that can be done with a simple use of a smartphone. But what way are we having some emotional support? And in my longer training, I give other examples. And then think about the family. When I've stayed in the hospital with a loved one that was an extended circumstance, just having someone come in and be aware of the fact maybe I needed a pillow or a blanket because I'm staying there. And then the staff thinking about if the illness is ongoing. And then someone's up there, you're also trying to juggle my job. I'm trying to juggle paying bills at home, or if their children are home. So just being aware that not only is the patient possibly overwhelmed with trauma, but also the family. So D, E, and F is a great protocol that's trauma informed. And then also compassion in healthcare. So back to our book on Compassionomics, which I tell the doctors, one of them I know, Dr. Stephen Treziak, I've interacted with him, but I don't get any commission for sharing about the books. But in the book, Healthcare, Compassionomics, they talk about healthcare is walking with people through the worst, most intimate moments of patients' lives. And it should literally be seen as a sacred thing. Few people are invited into that space as a provider is when someone is in this difficult place of their life. And that multiple studies, as I said earlier, 1,000 studies were reviewed that brought about this work that's called Compassionomics. Multiple studies indicate that many healthcare providers aren't even hearing their patients' worries. So in one study conducted in 1984 and published in an internal medicine journal, researchers took tape recorders. Now, I don't know how old everybody is on here, but I remember tape recorders. I had a Walkman when my boys were little, and I would go do my exercise with a Walkman with a little cassette tape in there. So they took around cassette tape players to primary care office visits, and they found that 77% of the time, physicians interrupted the patients within 17 seconds of their opening statements of concerns. And one of the things I really want to impress upon you with this trauma-informed education today is that some of the fixes for integrating trauma-informed practices into medical settings and treatment settings, they're not very costly. So when this study was done, 17 seconds before the physician interrupted the patients. And so this was so concerning that medical schools began to clamor and bring about communication skills and listening skills as a part of medical education, and begin to help with techniques added to curriculum to address this issue. So a study was done again 15 years later, and the outcome was published in the Journal of American Medical Association. And whew, they were relieved to see now, after 15 years, that providers were listening 22 seconds, up from 17, before interrupting the patients. And then something else that the second study yielded was that in this study, it showed that patients only needed 29 seconds to feel they were being compassionately and adequately listened to. So sometimes when I've been training physicians, I do a little role playing, and we just literally start the stopwatch and show 29 seconds is all that the patients in this study showed they needed to feel compassionately heard. However, in 2018, the Mayo Clinic repeated this study, and now it was worse than ever. They showed that providers were cutting off patients at 11 seconds. So right here in this training today, I'm giving you that little nugget of what research showed that patients needed to feel compassionately heard and what is going on as far as the science out there. Okay, and then we also see that emotional support matters, kind of tying into the DENF protocol. So in 2010, a Brigham Young University study analyzed data from 148 previously published studies that involved more than 300,000 participants with all kind of health conditions. And they found that those having a meaningful relationships was associated with 50% higher odds of survival. I mean, isn't that amazing? Going back to our ACEs study and healthy support networks. All right, here's one that I really fell in love with during COVID-19 that came from the Vanderbilt Children's Hospital, is that the workers in the Children's Hospital realized the children aren't seeing their beautiful faces. And so they had these small badges made of their entire face to wear on their uniform. And now that I've been training teachers, there's some schools that have gone to using this. And so that rather than just seeing the eyes of the provider, they see the warm face and the smile. And again, that is not a very costly intervention. And then the Schwartz Center, the Schwartz rounds, I learned about this when I was speaking at Duke University a few years ago at the conference on medicine and religion. I learned about Schwartz rounds and was working while I worked in healthcare to see about introducing this into the health system. I was not able, in the time I was there, and then COVID came, to get it implemented. But basically, Schwartz rounds are compassion rounds. And a gentleman that was an attorney in healthcare had cancer at 43 and died at a very early age. And he wanted to leave behind, Mr. Schwartz, a legacy of the fact that it wasn't, even though we maybe not able to cure them all, that we can care for them all. And Mr. Schwartz was so touched by the compassionate level of care that he wanted to leave behind as a legacy. And so they created the Schwartz rounds. And what the Schwartz round is it's usually held once a month, every other month. It's up to the jurisdiction of the particular hospital or health facility. There's an enrollment fee that you can pay, and the people from the Schwartz Round Center can come and do training. They have a library of topics, but it's things things that help your providers to not burn out, where you're able to process not the details of a particular case study, but sometimes the emotion. For instance, when one of your team members, now you're treating together your team member's child, or something that could, or maybe a violent shooting taking place in your community, and these individuals coming into the ED, and how are these things affecting your staff? And so in today's fast-paced healthcare environment, crowded with competing priorities, the human connection is often overlooked, leaving caregivers burned out and patients and families feeling fearful and suffering. And so through these innovative programs like the Schwartz Rounds, they're there to help be the charging station to caregivers, healthcare leaders, and others. And so some of the improved outcomes from the hospitals, several hundred around the nation now implementing Schwartz Rounds. You see improved teamwork, interdisciplinary communication improved, appreciation for the roles and the contributions of colleagues from different disciplines, decreased feelings of stress and isolation, more openness to giving and receiving support, and increased insight into the social and emotional aspects of patient care, increased feelings of compassion towards patients, and increased readiness to respond to patients and family needs. So when I was looking into the compassion rounds for the health system I was at and attended several webinars, one of the topics that they had in their library of topics was called hangry. And I was telling some in child life about hangry, and they all started laughing. They said, we know hangry. And hangry is basically when you are running from patient to patient to patient, and you as a provider have not gotten a meal. And now you find towards the end of the day, you're hungry, and you notice that sometimes you come out with a little bit of shortness in your communication to the patients. It's not their fault that you've not had a chance to slow down and eat. And so I never heard of hangry. Oh, but these healthcare professionals knew exactly what hangry was. And so hangry was one of the topics of a previous Schwartz round. Okay, and then also with Medicare population, which is a small but costly percentage of individuals that are being served in our hospitals. They come from every kind of behavioral health, addiction, homelessness, social isolation. And one of the things that healthcare providers and managers in hospitals will talk about is frequent flyers to the ED. And I know that the state reimbursement sometimes can diminish a bit when someone is there very frequently. And so there were some pilot programs going on in some healthcare systems that I've interacted with, where they have a social worker that gets the names and referrals of those that are spending 2 and 3 days a month visiting the ER. One time when I interviewed the social worker who was in this contracted program with a particular hospital, she told me of a gentleman who had stage 4 cancer and was living under a bridge, and he was frequenting the ED. And while there was really not a lot that could be done for his health situation, as she got to know him, she learned that he was a veteran and had a disability check, but he had fallen prey to the predatory lending institutions of his town. And so his income before it came in every month was already going to be going out the door. So she was able to put him on a budget, and she was able to help him find some assisted living. And the day she shared that story with me, she was in tears, telling me how that he was near the end of his life, but for the last 6 months of his life, he had dignity, living on his own, living in a healthier atmosphere, instead of just coming from the street to the ER several times a week. So more and more and more, we're starting to see some of these types of programs popping up, and they're great examples of trauma-informed care. Okay, in our last few minutes, we're going to wrap it up with the 6 pillars of trauma-informed care that SAMHSA talks about. And these are on the screen: safety, trustworthiness, transparency, peer support, collaboration and mutuality, empowerment, voice and choice, cultural, historical, and gender issues. All right, so number one is safety. The reason I like these SAMHSA pillars so well is because they're not a checklist. So I'm not giving you a checklist today, but again, I'm handing you a trauma-informed lens, and these 6 things need to be considered, that we are involving them in our service delivery to help better serve trauma survivors. Okay. All right. So who defines safety? Well, we have 2 sides of the coin here. We have the safety of the people that use healthcare service, and safety can generally mean maximizing some control over their own lives, and having somewhat of an understanding and collaboration when possible in treatment options. And then also the safety of the providers, which means having control over the service environment and feeling that there is a minimal risk in working with patients, and in your own physical safety and self-care, which we'll talk about more here in a minute. So what might safety look like? Now you see the photo there. I'm big about snapping photos. So if I come to your facility, I might be snapping photos. And you can tell from the color scheme, that photo likely did not come from a hospital, because I don't think they have a return department. But this was from Walmart. And, if any department might be difficult to work, think about returns, or customer service, and up there in a big sign in Walmart, happy to help, happy to help. All right, so some of the things that safety might look like is that you're a welcoming environment, welcoming to people, consistent and predictable. We may have somebody on the training today that is running a nonprofit that 3 days a week is offering some kind of treatment groups, and you're low budget. You might even be working another job to help sustain the income, because your nonprofit's not generating it. And sometimes we may have to certainly cancel appointments, and I know things do come up, but it should be the exception and not the norm. Because when people are living in instability, like those 300 or 400 kids that the school system told me had no permanent address, when we're serving trauma survivors that come from a background of instability, our environment is more healing when we have it consistent and predictable, and that we offer our services without shaming, without blaming, nonviolent, respectful of privacy and confidentiality. And then we have clear explanations of what is happening and why. Number 2 is trustworthiness and transparency. So we want to provide relationship-based care. In the book Compassionomic, they talked about, instead of blood pressure in room 408, or sprained ankle in room 409. And I know HIPAA drives a lot of that, but when we're in a room and interacting with a patient, if they could be called by their name, these things are just small adjustments. And then treating people with dignity and respect. And then if a situation warrants where a trauma story, is shared. I hear multitudes of trauma stories since I've began this work, and I hear them sometimes from the director of who set up the meetings, walk me to my car and tell me about unfortunate thing that happened in their life. And I'm always empathetically listening and thank someone for sharing their story, and then being listening and being present in the moment. I know in healthcare, time is not your friend, that so many patients have to be seen in short amount of times. But if you're in there for a couple of minutes or whatever, to try it all to be being present there, and not out of the room or on a device or something like that, but to be listening. These are small things that communicate to the patient trustworthiness and transparency, because trust and transparency and safety, these are foundations for healing. And then here's some things for responding when there's disclosures of personal trauma. Now, remember, a little while ago, I told you that we're not trying to find out the stories. What we're trying to do in this training is give you some skills to help you to better respond to victims of trauma. But here's some empathetic statements. I'm sorry that happened to you. What happened was not your fault. Thank you for trusting me by sharing your story. You're not to blame for what happened to you. And then if you're in a situation where maybe it's going to be a direct relationship through treatment or some ongoing health and patient relationship, maybe there's an opportunity, as some physicians here regionally are doing now, to start talking about the person's outlying sources of health and what could be some of these sources of toxic stress, and to begin to help educate some patients, as a local pediatrician is doing, about understanding ACEs as related to your physical health. All right, number 3 is peer support. According to SAMHSA, peer support is a flexible approach to building mutual healing relationships among equals based on core values. SAMHSA said that peer support needs to have all these 5 ingredients: voluntary, non-judgmental, respectful, reciprocal, and empathetic. And so some great examples of peer support are groups like AA or NA. Those are long-standing, very successful, to some people, means of treatment. And that's really through peer support. And so what could peer support look like in healthcare settings? Well, by referring patients and families to a support group. You know, people who may have children with a certain disability or an illness, to be able to have other families to talk about, even through a social media, closed group social media page. These type of things have really been shown to have some healing value. And then create spaces for patients and families to interact. You know, our waiting rooms are oftenly an organic, when I've been up in ICU waiting room overnight, when I had health family members in ICU for several days, one up to a week. If the coffee pot was empty during the middle of the night, somebody might say, I'm going down the hill to McDonald's for coffee. Anybody want some coffee? And I know, again, now with COVID, a lot of those things have been altered, but I am thinking at some point we're going to see those activities again. And what is that? That's an organic way that we're having some interaction between families. I know when both my grandchildren were born, I'm the grandma that rushed back from the beach 6 hours away because my daughter-in-law was in labor, and I got into the hospital in the night, and we had other families waiting, and we're all waiting on the birth of a new baby or a grandbaby or a niece or whatever the situation. And just the chatter in that room was, you could just feel the excitement, even though it was late in the night. And so what is this? This is kind of an organic type of support. So we don't want to try to discourage the interactions with families and patients unless there is a medical reason to do so, which certainly now with COVID, there is. And then here we had the Cancer Research Affiliate that was local. All their staff became trained in trauma-informed care, and they realized that many of the families they worked with, there was a lot of anger, and rightfully so. What could be more traumatic than a child with a childhood cancer? And so this group, great team put together, were able to secure a psychologist to come a couple of times a month and led an anger management conversation. And one of the people that attended the group, one of the families, went home and shared on social media about this group and how helpful that it was. And apparently that person was monitored by a lot of families that also had children with childhood illness. And they were writing, how could we join? Just because of this person saying how helpful that group in a cancer research clinic was. And then one of my favorite stories from this group was they told me in August before COVID, was that they had 5 children they had treated for childhood cancer for 2 years. And during those 2 years, these children were all the same age, unrelated. But these children had never been able to go to daycare, preschool, church nursery, nothing, because their immune system was compromised through the delivery of these treatments to bring about, remission. And so now they were all at the age of going into kindergarten, all in a healthy place that they're able to go into kindergarten. And this team here realized that these children had never been in school in their life. And so they decided to have a life skill class. And so they got permission from the parents to bring the children in on one day. And one of the social workers in the group, they took the children, lined them up, taught them about raising your hand, introducing yourself, took them down to the cafeteria and went through the line and how to order a meal, put it on your tray and open milk cartons, find the restrooms, because this group knew that those children who they had been helping all this time to overcome this traumatic illness might have a trauma occur by just coming into school with no prior experience. Now, is that something you would have ever expected to happen in a cancer research clinic? But that is an example of trauma-informed approach. And when we're talking about peer support, we want to talk about the care of our providers. So vicarious trauma is the expectation that we can be immersed in suffering and loss daily and not be touched by it is unrealistic as expecting to walk through water without getting wet. So some ways that providers can be protected from vicarious trauma, and leadership needs to stress these things in keeping the health of our staff, even more so now with COVID. Talk with colleagues about how your work affects you. And that's one of the things the Schwartz Round does. Allow others to talk to you about how their work affects them. And then processing the stress of the job is not a character weakness. And then taking breaks whenever possible during your workday, and seeking out or establishing a professional support group. And then recognize your personal limitations and set limits with patients and colleagues. Enjoy life outside of work, and then having a personal safety plan. And so one of the things that I use when I'm training law enforcement is there is a professional quality of life scale, the ProQual, and you can find it online. It's free and it's self-scoring. However, there is a free app you can download from the App Store called Provider Resilience. And the professional quality of life scale is on the app. It's not a medical or a psychological test. It's meant for people that work in compassion professions. It gauges your answers into 3 classifications. Professional satisfaction. Woo, I delivered triplets today. What a day, I love my job. Or compassion fatigue, long hours. When COVID first came, I saw heart-wrenching photos of caregivers looking through windows at their own children just because of the unknown of not wanting to expose, their own family to anything that as they've been working long hours in the hospital. And then secondary trauma, which for law enforcement can be most dangerous. In 2018 and 2019, the leading cause of death to those in law enforcement was suicide. And so we're seeing often with law enforcement, there's not enough resources to help process this trauma. And so here's a couple little screenshots of what the Provider Resilience app looks like. Again, it's free. It's going to show you how to do the ProQual. You answer about 20 questions, like the far picture on the right. Have you taken a day off within the last 60? And you just zip through it, answering yes, no, and your score is immediately generated. And you're going to see, am I scoring secondary trauma? Am I scoring compassion, satisfaction? And then there's going to be some things like simple stretching exercises. So I recommend that for self-care. All right, number 4, we have 3 more here: collaboration and mutuality. So in the SAMHSA 6 pillars, it talks about that we need to partner and level the power differentials between staff and clients in healing relationships, and these things will bring about greater patient care. The medical arenas are at high risk for perceived or actual power differentials. You know what one study showed is that who patients talk to more than anyone in an overnight hospital stay. Now, this was pre-COVID, but it showed that patients talk to housekeeping more than any other hospital staff. So that's why in my experience, we were training housekeeping staff, and you could just see how that understanding their role was important in patient in understanding patient recovery. Just that simple gesture of kindness and coming in and cleaning in the room and just those interactions. Okay. All right. So we see that treating patients and families as equals reduces fear. All right. And that individuals' strengths and experiences are recognized and built upon. Number 5, and that we help individuals to have a voice and choice, that their choices are validated and that new skills are developed, and that organization fosters a belief in resilient. The clients are supported in developing self-advocacy skills and self-empowerment and welcoming questions and collaboration about care and discussion. And so we want our health settings, our treatment settings, to foster a belief in resilience. One of my greatest examples of this, it's a made-up story, but it comes from Joyce Meyer, who you may be aware of as she's in the faith-based community. And Joyce is a survivor. Her father was a violent alcoholic, and from the age of 9 until the age of 18, Joyce was raped by her father over 200 times. Often he'd come in from work late at night and once he was drunk, come in her room and load her in the car and drive her to the end of the road where there was a cemetery and just do unspeakable things to her. And her mother knew about it, but her mother was afraid of her father. And so Joyce found resilience in her faith. But in one of Joyce's talks, she talks about this story, which is, to me, is a wonderful example of resilience, that this farmer had a donkey. And the farmer and the donkey worked the field year after year and began to process the dirt in the spring and sow the seed, and in the fall bring the crops in. And I mean, this farmer and donkey had a great working relationship. And after many years working together, the farmer prospered to the place that the donkey wasn't really needed. The farmer was able to buy a tractor. So the farmer sent the donkey off the back field, which is pretty comfortable retirement for the donkey. Well, one day the farmer came out and couldn't find the donkey. And as he looked around the farm, he heard a distressing noise, and that really bothered him. So he really began to hunt for the donkey, and lo and behold, found the donkey had fallen into a big dried out well shaft. So about 40 feet down, he sees this petrified face of the donkey having fallen in the well. And so now the farmer thinks, you know what, I don't know how I could rescue that donkey. And, I don't need the donkey anymore. I've got my tractor. So the farmer goes to the barn and gets a shovel and comes back to the dried out well. And he takes a scoop of dirt and throws it down 2 or 3 times. And the donkey at the bottom is realizing, wait a minute, I thought we were friends. And now what are you doing? You're trying to bury me alive. But the donkey got the idea that every time a shovel full of dirt hit his back, he shook it off and stomped it down, shook it off and stomped it down. And the very dirt that was meant to end the life of the donkey, the very dirt is what the donkey used to escape. And whoever is on this training today, whether you're a treatment provider, a pharmacist, a physician, of all the things you're proud of on your resume, I hope that you'll add to your resume that you are someone that was able to help individuals shake off the dirt and walk into a new life. We can't help it where we start in life, but trauma-informed care takes in our thoughts that we can help people have a better finish. All right, and then our last one is cultural, gender, and historical types of trauma. And these are things that for years we've been beginning to move past, but now we see a lot of times in communities with racial divide that we need to do a checkup on ourselves. Are we offering services that are totally cleared of gender and religious or racial or ethical biases in services? And I could give examples of some of those. But to wrap it up, what is trauma-informed service? We focus on understanding the whole individual and the context of their life. It's infused with the knowledge about the roles that violence and victimization play. We're designed to minimize the possibilities of victimization or re-traumatizing. We're hospitable and engaging. We're designed to facilitate recovery, resilience, and growth, and respectful of a survivor's choices and control over their recovery. And here's my content sources. and my contact information. And I really thank you so much for joining this training today. I don't know if anyone is going to pop on and dismiss you, but that's the end of.
Let me pop on. I'm sorry, Becky, and say thank you very much. I know people kind of popped in and out. Some people did, but almost everybody was here for the full time and got the benefit of your expertise. You know, it's amazing to me. I can see why Taranya recommended you so highly and why other people take advantage of you, because you just combine not only the ability to communicate really well, but the breadth of your experience is really awesome. And I feel very fortunate that you were willing to dedicate some time to us today and help us all understand and see, you know, what additional things we can be doing to help our communities. So thank you very much.
Thank you.
I am going to ask everybody to, if they would, go back to your dashboard and provide some feedback on this training session. I know Becky would welcome that, as we would as well. But again, thanks to all of you who took the time out of your busy schedules to participate. And once again, if we were in a room, we would all give a round of applause to Becky, but we can do the wavy hands instead, okay? Thank you very much, everybody. And we hope to see you tomorrow morning for our last plenary session, which starts at 9 a.m. Central, 10 a.m. Eastern. We will have some recognition for a few folks that we are honoring for the work that they've done in this area. And then the rest of the morning, we will spend some time doing some prioritizing of the needs that we've heard about. And that's going to help us understand kind of what are our priorities, not only the organization, One Tennessee, but each of our respective organizations, and hopefully some collaboration opportunities where we can continue working together. So a couple of things. Thanks to Becky, provide some feedback, and plan to join us again tomorrow at 9. Have a good afternoon, evening, everybody.